We're ready? Okay, welcome. We're with the Mental Health Awareness Month, and this is with SCIPP at the Restoration Community Church. And we actually have a panel of individuals that are actually going to help educate us and deal with issues with mental health in the community. And first off, we're going to have them introduce themselves.
I'm LaDonna Pratt. I'm the high school counselor at Scott City R1 High School and an adjunct psychology instructor.
I'm Catherine Hart. I'm the community liaison at Southeast Behavioral Hospital up in Cape.
David Terrell with Boot Heel Counseling Services, Executive Director.
Chris Griggs, Scott City Police Department, Sergeant.
Okay, right off the bat, after we got the introductions done, we're going to have the panelists talk a little bit about who, where they're coming from and from the mental health awareness aspect.
Okay, so I work primarily with ages 14 through 18 and then some beyond. We do have students come back and reach out to us. Right now, I think the trend for the teenage population is anxiety is huge. I see that in my office on a daily basis, where coping skills, partially I think because of the pandemic, and I hate to even bring that up, but that has really played a huge part in students isolating, not being able to problem solve and handle crisis. I don't know if the rest of the panel find the same thing, but we have students who don't like crowds. We have students who feel overwhelmed with homework, instruction, cafeteria, home life. You know, outside relationships have suffered a great deal, not just from the pandemic, but personal opinion, a lot of social media issues. When we can hide behind a keyboard, that limits our ability to interact appropriately with one another. A lot of harsh posting can be done anonymously, which then that comes into the school. We try to avoid that. We try to shut those things down, but our power is limited in that capacity by laws, by rules, things like that. But students not knowing how to handle things, not knowing how to deal with emotions, and being hurled into the world shut down. You know, none of us were ready for that. But being thrust into that type of situation has severely limited their ability to cope. And so we have a constant flow in the district K through 12 of students struggling to handle issues. We do have a social worker, which is a phenomenal addition to Scott City School District. She operates K through 12, and believe me, she earns every penny that she gets. Her name is Stacy Kilby. So we collaborate a lot. Stacy Cossey is the elementary counselor. Emily Henson is the middle school counselor, and then I take the high school. So Stacy Kilby, the social worker, works tirelessly on connecting families and students with outside resources as well. We do also coordinate a lot with Boot Hill Mental Health, Southeast Behavioral Health. You know, we're willing to help research any services that we can. We have folks come in and meet with our kids. We will do whatever we can to try and help meet those mental health needs and crisis needs for our students. As far as suicide, this is suicide awareness as well. I'm very grateful that we don't have a tremendous amount in our school district. I think because we try to jump on those things very quickly. We take no comment, no threat for granted. And we immediately assess, is that student in crisis? And if they are, then we put them in contact immediately with services. We don't leave them alone. We bring in the social worker, we contact parents, whatever is needed to keep that child safe. We do educate on this. We, use rating scales. For example, on a scale of 1 to 10, how much do you want to take your life? Or what is your intent? So the rating scale, 5 towards 10, that's when we kick into action. If they have a plan, if they have the means, and if they have the intent, then we move forward quickly. So.
Again, I'm Catherine. I'm from Southeast Behavioral Hospital. I know most of you are probably familiar with Southeast Hospital. We are a joint venture with them. However, they own about 25% of our joint venture. So we are a specialty hospital, behavioral hospital, off of South Silver Springs Road down from Cape Central High School. We're 102 licensed for 102 beds. Currently, we're operating, I think, a little over 30. So we do have an adolescent unit for 12 to 17-year-olds for inpatients, and we also have an adult unit that's been open about a month, so that is 18 and above. We have hopes to open our geriatric unit back up in the future. One of our major setbacks has just been staffing, so as soon as we can get adequate staff, we will open that unit back up. We also have intensive outpatient programming, so if you come in and you're assessed for you could go inpatient, but you could also qualify for our outpatient programming, which is, intensive outpatient is 3 days a week for 3 hours each session. And then we do have a partial hospitalization program, which meets 5 days per week, Monday through Friday, and that's 5 hours per session. So kind of like LaDonna was saying, most of our kiddos that come in, a lot of them are suicidal ideation is a big one that we see, but we do also treat sometimes just severe anxiety, depression. It is very, very present in our community. So we have a very holistic approach. Group therapy has been amazing for our patients. And then, especially if they go into our outpatient after they're discharged, that's been a great resource for our community. So we're excited to continue to grow, and I hope I answered any questions, but if you have anything for me, I'm here to hopefully answer all those. So we're doing our group therapy. That's our main programming, and we also do some med management, but we're also teaching them coping skills, things that they can add to their toolbox to go back into the community and cope with their daily lives. So we're trying to set them up with ways that they can handle anxiety, exercises and things like that our therapists kind of guide them through those struggles. Yes, ma'am? PTSD. That's probably, I know that we have, group therapy is our main thing, but we would break off into smaller groups. So if we have a group dealing with PTSD, that's something that our therapists would look a little bit more closely into, and we modify programming for each individual patient that we have. So, and it varies. We take all kinds of different situations going on. Hope that answered your question.
I have a question. So back when I was assistant pastor at Skyline Church in San Diego, we ended up with a pastor that was a therapist, he was licensed, all that. He was on staff. So they started a thing called My Therapist Says. Once, like a quarter, they would bring a panel. Sure, they'd sit up there, and people would run cards up to just start asking all these questions. And hundreds of people started showing up, but they always had these questions they want answered. So I guess what I'm asking is, would that be something potentially that you might be interested in? I mean, for that night, but then was, how do you get them from that then to the actual, the offices for counseling, for therapists? But it was really amazing that the information that they did not know.
Right.
Just to run them a card that says, hey, it was really amazing. I'd be quickly on that night, we'd be blown away with how many hundreds of people here just asking questions because they want to know.
Yes.
So maybe down the road would be something I'd like to see here on,
Yeah.
My Therapist Says.
Or maybe even take a box back home with us and answer the questions at the following meeting or something like that. Because I don't know that I'm always prepared with those, or I don't know that I'm credentialed to answer some of those questions sometimes, so might have to do a little homework, but.
It was just pretty laid back, but it was just, you know, when the basic questions that they were answering on those cards, people wanted to know, you know.
Right.
You know, and my wife was she was an admin assistant at the time. He was the busiest person on staff for the guests, to get them to clinics and counseling
Yes.
sessions outside the church, which really helped the people, so.
Mhm. Thank you.
Sometimes those things are less intimidating
Mhm.
than to individually show up at a group where you have no idea what to expect. You
expect.
know, accessing mental health services is certainly not something that most people in this day and age, unfortunately, will say, yes, I do. You know, so like you said, the Q&A as far as written cards and things, you know, having a website or something that would provide those answers is less intimidating and more people can be reached.
And more accurate probably with the responses.
I was just going to echo that
Yeah.
point. To Catherine's point, you know, if that is the intent and the focus, being able to have a panel of specialists, you know, licensed clinical social workers, LPCs, you know, things like that, that can answer some specific questions. Yeah, I think that'd be a fantastic idea. You know, maybe quarterly or something. So,
And
yeah,
I think we
good
all
ideas.
have the resources to accompany us
Exactly. Yep.
if, you know, we just do good planning for that.
Yeah,
So.
so what happened, once
I agree
someone
with
asked
you.
you questions, another card was like flood. Everybody felt comfortable thinking,
Sure.
well, I can ask that too, and kind of a small fish in a big bowl,
Mhm.
not singled out. And I think that would work, and of course, the parents would do the best they can. Or they would say, well, we'll refer you to, just get with me later, and then we'll set the program.
Right.
It really worked out. Okay.
Okay, Dave?
I'm sorry.
That's okay.
Through that conversation, it made me think about something that I had forgotten. So Paul, and to everybody else, I honestly am not much of a talker, but when it comes to work and it comes to us doing what we do, yeah, I can talk for days, you know, about things just because of the content and I think the passion that we all probably have for what we do. So again, David Terrell, I'm the Executive Director at Boot Hill Counseling Services, and I'm going to take, I guess, the approach of just kind of explaining some things that we do, if that's okay. And and so we are the administrative agent for Service Area 20, which encompasses Scott, Stoddard, Mississippi, and New Madrid counties. And we're a community mental health center, and we're also a certified community behavioral health organization, which is a CCBHO. And so when terrible with names, LaDonna mentioned Boot Hill Mental Health, so it kind of aged me a little bit. And so I started with the organization in 1992, just after the name change went from Boot Hill Mental Health to Boot Hill Counseling Services. And so some of us have been around a minute and remember, and we still are referred to as Boot Hill Mental Health on occasion. We are in the process of going through a rebranding because of our growth. And so we may not be Boot Hill Counseling Services sometime in the near future, except only because of the growth. And so, so again, I just kind of want to touch base on that and segue into many different things. When you think about counseling, you think about what you had mentioned with PTSD and just, you know, and the talk therapy and the group therapy and things like that. So when we think about Boot Hill Counseling Services, you think about counseling versus all of the many different things that we do, one of which is counseling, obviously. But we also we see thousands of people a year, and not only for the counseling component, but also rapid response crisis services. And so we all, again, work so closely together, each one of us on this panel, whether we knew each other or not, we know each other by organization because we work so closely together. And so we have, to her point of mentioning suicide, you know, we have a zero suicide plan and program in place, one is too many. And we all are affected by that. There's at least 100 people affected by each suicide. And it's just, it's one of the worst epidemics, forgive me. Pandemic's on my brain. But it's one of the worst epidemics I think we can ever face. So we have crisis services every day of the week, every minute of the day, on call and walk-in services at our offices. And so, with that being said, our 800 number that's on our brochures and things like that will be going away because of the 988. And so the national suicide hotline, 988, is so much easier to remember, similar to calling the police or the fire department with 911. So again, just with regard to the crisis services themselves, I just cannot emphasize that resource enough, because it is, there are some weekends that they're just so busy replying and responding to crises, whether it's handling it over the phone or going out mobile and going out on police calls or school counselors getting their calls and things, because I know that they get them too. And in such, utilizing, Southeast Behavioral Hospital. So community psychiatric rehabilitation program. So we, in our field, use a lot of acronyms, and CPRP is what we refer to it as. So that's what I cut my teeth on. When I started in the field, I was a community-based social worker. So we go out into the community so that people don't always have to come to our office for services. So social workers will go out into homes, and they work with all ages, whether it's youth, adults, and work with the families, and then folks who are also engaged in their lives in the community. And so you have to obviously qualify for those services through having a serious mental illness or a severe emotional disorder. So just as, for instance, ADHD, for some of the kids, and then schizophrenia, major depressive disorders, PTSD with adults. So we have community-based staff that go out into the communities that work with folks with those things, with both children and adults. They also qualify for medication services through that. And then we also have something called psychosocial rehabilitation, a day treatment program. That one is only for the adults. And so, again, if you qualify for the CPRP services, then you qualify for that one. So we have vans, and we have staff that go out into the community and then actually bring folks back into one of our offices to provide group type of interaction with their peers, to be able to, some people have never had the opportunity to even learn how to read instructions to make a hamburger helper meal, or wash clothes, but also be able to be able to meet with peers to discuss how they cope with things together, and learn from each other. And so medication management, we have psychiatric mental health nurse practitioners and some psychiatrists, and then also some general medical doctors that will continue medication management. So those are also services, and as we've mentioned, the pandemic kind of turned things upside down, and we had to very rapidly, all of us, determine how we were going to provide services. So it really made us respond to the need, not only that we already had, but what we had experienced because of the pandemic. And while therapists and professionals are also helping others, we're also dealing with our own anxieties, if you can imagine. It didn't mean that we weren't also having anxiety, and things. I think we were all experiencing those things. So the helper helping, others while also trying to help ourselves, through some things. My point in getting at that is, with medication management, with counseling, we'd like for people to be able to come into the office, but we also do have some telepsychiatry and telehealth capabilities. So when people have COVID and they can't come into the office and we do need to see them, we can see them virtually. And so we were also doing some of those services and had to do that rather quickly to be able to meet the needs. We have something called a healthcare home program, and it's not to be confused with home health care. So the healthcare home program is a staff of nurses who, and it's a Medicaid-only program, unfortunately, but the state implemented that, and at that point we were able to ascertain information through MoHealthNet to be able to see, for instance, what some of our patients were doing in terms of medication management or following up with their diabetic management, high blood pressure, things like that, so that you can see what providers might be prescribing what different classifications of medications, so that you knew more and more about what risks there were. And so it was a huge undertaking, but also a huge savings of tax dollars, because it prevented people from going to the ER for care and for services first. And then it would also get prescribers to talk to each other and communicate better. And so it would keep people out of the hospitals more effectively. We have a co-occurring disorders program, which is actually called Integrated Treatment for Co-occurring Disorders, ITCD. And that in and of itself is for clients who experience a serious mental illness and a substance use disorder concurrently. And so we have specialists that provide that service. And then we have a standalone substance use disorder program as well. It's only an outpatient program. We have started something called an emergency room management or emergency room enhancement program to also manage folks going into the ER frequently, but they're also experiencing behavioral health crises or needs. And so we will engage folks to be able to go and at least offer services and try to provide them with services, or to reduce, again, those visits. We have employed peer specialists. So with that service, the peer specialists are been there, done that. I'm recovering, and showing what recovery looks like and what that means. So they have to go through training and become certified to provide that service. And we also have family support providers. And so family support providers are similar to peer specialists, only they are more on the side of helping the students and the youth and their families with families are struggling, for instance, being able to work with their children with special needs or something as well. And so the family support provider is at least somebody who has had that level of care providing services to somebody, and again, showing the resources now to how to manage. The veterans program was something else that we added. So we have a veterans liaison. And so we may have somebody come in and they don't know how to navigate the VA program. So we'll help them, connect them with the VA services, but also provide services to them through Veterans Choice programs. Unfortunately, some of them are homeless. We have a homeless mentally ill program. So we go out again into the community to work with those. We were talking about just different folks that work together. I know that work very closely with them. So we have a community behavioral health liaison. So we have actually 2 of those, and they are assigned to work closely with folks like Sergeant Griggs, right? So with working with Sergeant Griggs and his department, they may run into somebody on a call who, again, might be suicidal or experiencing a psychotic break. They are the first people to respond. And so when they get there, they probably don't need to be arrested and go to jail. They probably need services. And so for us to be able to have people they can call on and be able to respond and outreach them, there's a referral program and a referral system for them to be able to get those to us. We work very closely with the court system through that as well. And then when they need the help, we are also working with the hospitals to get them the emergency care that they need. The CBHL has expanded to also include what's called a YBHL, which is a youth behavioral health liaison. So the youth behavioral health liaison provides care to those that are engaged in the juvenile justice system or something, and so to also assist them in that level of care. The CBHL also works with local police departments through CIT training. The CIT training is crisis intervention training, and it is, again, to assist with, how to de-escalate situations. As police officers, you go on a call, and I'm going to let him speak to this more, but they go on a call, and they're in charge of that situation, so you don't always want to lay hands on somebody, but if there's something going on, how do they de-escalate? How can they speak to address the psychosis that somebody's experiencing and the dangerous situation that they're in? So our staff, with a team of others, will provide a week-long training. I mean, it's 40 hours of training. And they also, at this point, also get that through the academy. So they come out of the academy with that training as well. So we've come a long ways with regard to that. And something that we're always looking for is, it's called treatment family homes. And so when we have youth that need, they may be displaced, but they're not in the foster care system. But we go out and train folks who might feel called to offer services to them, so they actually take these youth into their homes and get specialized treatment also, or specialized training also, to provide treatment to them, because there's a level of intensity that these kids and their families need at that moment. So again, forgive me for speaking so much, but there's just a whole lot going on. Sergeant Griggs and his department may go on a call, and there may be a dead youth, an elder. They deal with that, and so at that point, what also do you experiencing? Speaking to the PTSD thing, and so there's something else that we're working on in our community, which again is peer-led for officers to be trained. So officer to officer, because sometimes you don't want to go into the counselor. It's just face it. That is still a stigma. It still exists, but I think it's being reduced. It's being broken, if you will. And so, but that's something that we do. We'll go out on calls to do debriefings, and things on different calls. And then we offer trainings, and we all will partner to do trainings together, and whether it's mental health first aid trainings, which are free. We offer these to the public. So if you or any of your organizations or anybody wants some of those things, mental health first aid training is one of them. Another one is called QPR, question, persuade, and reply or response. And that one is suicide awareness and response training. I'm going to pause and just kind of give it a break for a moment, and I can speak some more on some things later.
Okay.
So.
Anything in place for spiritual needs? So I've been involved with sex trafficking in Arizona, and not involved with street nut, cottages, and all sorts of programs. And some of the people who look for that spiritual end, I'm not talking about any pastor just going into somebody that's qualified. In the churches, in the Wesleyan denomination, we had 10 years ago, we moved away from being pastoral counselors to being trained as coaches, because we realized that for decades the pastors didn't have all the right answers, and they really, I always felt they should. It's nice to see them, farming people out and saying, look, I can't do this for you. Let me get you to somebody like yourselves that are up here, which is really important. But also there's that spiritual part where somebody can walk and say, well, I don't know, is there I'd like to talk to a spiritual counselor, or somebody that at least, might meet that need. Is there anything in place for that?
Yeah. So as a clinician, sometimes I'll get calls. David, do you know a Christian counselor? And for me, some people knowing me know that I'm a Christian as well. But it's really not for me to disclose of somebody else's personal nature of things. But I think when people come in and they share, you'd be surprised. self-disclosure and some of those kinds of things but we don't have a specific partnership or anything like that with that. But that's not to say that wouldn't be anything that we wouldn't look into doing. Maybe having some resources or conference or some kind of a training of sorts. So never rule it out. Yeah.
Okay, next.
I'm kind of like David. I'm not much of a talker, so.
That's okay.
So, a lot of what we're going to deal with on a daily basis, like David mentioned, we get called to, most times we don't have any idea what's going on. There are times we find people that look to be at some sort of crisis. We do have training for those such events, but sometimes you just don't understand or know what's going on specifically. So what we try to do, our responsibilities for that is we try to see that they get the resources and help that they need. Not everybody that we go to is committing crime in those scenarios. So we try to make adjustments for ourselves as well, because David's right, in this business we see things that we just don't really want to talk about or have to see again. And sometimes it's necessary for law enforcement officers to seek counseling like this as well. But the mental health part of this, we see a lot of psychosis. A lot of that's brought on by narcotics and drugs. That can be pretty difficult to handle and pretty difficult to deal with, because we see violence from that stuff. We see people that may have been up for days on some sort of narcotic binge, and they're completely unreasonable, they're completely out of their mind. And as law enforcement officers, we not only have to protect ourselves, we have to protect everyone around them. And that can be pretty challenging at times. But I think mental health in law enforcement, and like David spoke about a while ago, has come a long way. We've made some advancements over the years, and even since I got in this business some years ago, there's more of an education that we have with this now. And I think that's great, and I think we should continue that part of it. I think these meetings are great, so we can kind of get an idea of where everybody stands on these views. If we go to a call, and the circumstances are typically different every single time, we are going to do our best to get the resources to them that they need. And that can be challenging as well. It's not always, well, we can call an ambulance to get them to Southeast Health. That doesn't always work that way. Ideally, we want an ambulance to come in partnership, and we will take care of the necessary what is for the individual we're taking care of at that point. But there are times where I've seen people, well, I want an ambulance, they get there, then they get down the road and they jump out of the ambulance. Those are issues as well. And we see the majority of what we deal with is narcotic psychosis, it's medication, PTSD. We deal with that quite a bit. Someone with PTSD or schizophrenia may be off their medications and have been for some time. Now they're unreasonable, and you're going to this not knowing, number one, their history, number two, what kind and how much medication that they have. So again, that is for a very short amount of time that we deal with this. There's a lot to go over and a lot to do. So hope that helps some. If you guys have any questions, just address me.
Well, one of the things I want to do is there's a couple things we want to go over, and then we'll actually open it up to more questions from the audience, from other people. But I know mental health awareness, I mean, that's a big cloud. I mean, it's all over there. There's so many nuances of that. And so my thought is, how does that affect a community like Scott City? What is something that we need to be aware of, and what is mental health itself? So that brings off to the panel. I mean, I know that some of you actually brought up some of the topics in that, but maybe if we can look at the whole scope of what this big thing is.
I think in my perspective, availability of resources and recognizing what those triggers are, what those cues are, and that's something that I work with the student population on, primarily individually. But, what feelings are there? What issues, what situations may trigger that anxiety? What's the difference between having a bad day and depression? You know, the definitions of these things, the effect on their life, and I think working to connect with outside resources, not just inside. There are some things that I clearly am going to refer outside of school every time because I have a dual role as well. So a lot of times it is better for that ongoing support to be outside of my office. So I do refer, again, recognizing the warning signs, the triggers. The more education we can provide on that, the better the community in general is going to be. Having panels like this where perhaps parents are involved so that they can also assist in finding that balance, because that's kind of what we're looking for, is a balance. We're going to have good days, we're going to have, you know, not so good days. But overall, trying to find that balance where one doesn't outweigh, the negatives don't outweigh the positives all the time. When that happens, that would be chronic, and that's when we, you know, begin to refer. So education is imperative.
I think she covered it, but I remember at the suicide convention that we just had up in Cape at SEMO, there was a speaker, one of the keynote speakers, that talked about soul exhaustion. So also, before you ever get to the point of needing treatment, just, you know, feeding your soul and making sure that you're partaking in things that bring you joy. And, you know, I think with we keep bringing up the pandemic, but that has been a huge thing with our adolescents that we've noticed is, you know, going to online schooling and being isolated has really been what's affected that anxiety piece and brought that to be so prevalent. So, you know, which leads to soul exhaustion. So, you know, just feeding your soul. It's not always that you maybe need to rest or, you know, just do something that you enjoy, and finding a good group of people to be around and involved in too, so that you don't get to that point. So I think that that's important too.
I think education is very imperative for mental health. Again, we deal with it because we are called to do that. We arrive, we just don't typically know what we're about to get into or what to see. However, mental health, when it comes to communities, some people just aren't really aware of what that is. And I think that it's good to try to get resources out to the community and try to understand a little bit more of what that actually means and what we typically deal with. And I think every one of us on this panel from time to time has seen different changes with that. And I think education is probably where it's at.
I didn't want to jump right in there because I spoke way too much. But I just agree with everything the others have said 100%, and really am encouraged by those answers too, because of it being focused on self-awareness and community, and that's what we're all here to do. To the point that, you know, when you were speaking, Catherine, you made me think about just what came to mind when she was talking was hope, you know, and just making sure that we're still trying to give people hope in light of everything that we're all struggling with, whether it's, you know, we were just talking about a cancer diagnosis, you know, and just different things that life throws at us. You know, there's still hope, and for us to be able to spread that hope. But the other, with community awareness and for us to be able to just connect, we not to intentionally necessarily sing Kumbaya together, but we're in His together, and to the point of something I was explaining a moment ago. I wasn't texting, I was researching, looking something up, and it was specifically mental health first aid, because the training hours had changed over time, and now it's 8 hours. And so it's an 8-hour training to assist with the recognition of behavioral health symptoms. And so mental health awareness, you know, what is this that we're seeing? What is this that I'm experiencing? What is this that my son or my daughter or my grandmother, whatever? To have that level of awareness And then to be able to know where to refer to and how to get those services. And then the QPRs, the question, persuade, refer. That in and of itself, again, suicide awareness. And so that's, I just echo what they're saying, 100% and totally. Something I did leave out earlier that to me is extremely important is that we as a community mental health center have a sliding fee scale. So we're not going to turn somebody away, because of the inability to pay. We have that level of care and that level of funding, which if somebody also qualifies, also includes medication management. And so we have a specific budget for those things as well. Because, to the point that I think Catherine would make would be, they'll do what they're doing in the hospital, help them, help stabilize, give them medications. They're back into the community, and then what? Where do they get their medications? And if they can't afford it, where do they go? So that to me is something that I left out that I just cannot, ignore. Something I wanted to share. And then the school-based services that we also offer. We have got a couple of counselors in certain school districts that we're still trying to work on expanding. But to your question, that awareness is integral.
I think that awareness is because, otherwise, a lot of people have a hard time understanding the idea of mental health. It's not a physical disability. It's something you can't see. It's something that is non-tangible, but that there's reactions.
Yes.
And I think, as the panelists had, all of you actually said, is education is the biggest issue of letting people know what it's about, what's going on. And families, I know that kids that eventually develop mentally illnesses and issues, that families, you're pretty much giving them a stigma, and they don't know how to deal with it. And they'll deny it as much as they can, but eventually they can't.
Right.
And that's a burden to the family, and trying to cope with that and how to help support that. And that actually affects the community too. And it's just a matter of going back, as you had said, getting the information, getting the resources, getting the services that they can provide, and getting over that hump and accepting things.
And that was another thing I think LaDonna and David said, don't take anything. No threat is, not serious. If someone's coming to you and they're telling you their thoughts and what's going on, you need to tell somebody. I think especially with parents, there's a stigma. Oh, nothing's wrong with my kid. They're just they're hormonal and they're just a teenager. But if they're telling you that they want to end their life, do not take that for granted. Seek, help immediately. So, and be supportive.
One of the things,
Have a greater role than maybe they're playing, because every Sunday, just look at churches on Sunday, and you got 50 churches in Dayton, you got 10 or 12 right here, you got 20 over there, and there's this huge congregation of people they're meeting, and they're dealing with children, and they have all this. They to recognize that, so that like you said, we have kids that come in. I remember years ago, sitting there and I was just the interim children's pastor. I remember a little 6-year-old trying to go to worship, and she just looked at, she froze, and she said, Pastor Bobby, I suffer from anxiety. 6 years old. And I never forgot that. It just broke my heart. She couldn't walk from there. So every week I'd walk with her to get her on, and then finally one day she's on the stage. But it was a long process. But I think that we need to do a better job recognizing, instead of just saying, oh, Mom, it's okay. Or really sit down and talk with the parents and get them referred out. But we see these people, we see these families. And it's more than just preaching from the pulpit. We live in a world where everything that's impacting, it comes in here. Whether people want to believe that or pastors don't believe that. It's here every Sunday. The anxiety, the suffering, drugs, addictions. We have to, walk through those waters. It's not clean by every Sunday. So I think the better we're trained to recognize, or like my staff would be, then we can say, yes, we need to refer those out. And the best thing we can do is be honest with them and say, look, we see this issue. You really need to do this.
Right.
It's going to be, us praying for you. I believe 100% God can do without this. But God created two people too. So He gave you the skills to take it to a level God can't do.
One of the things I did want to bring up that I didn't touch on earlier is the computer system that we have at school, and this is just kind of an FYI to ease minds. Our staff is all trained as well to recognize signs and symptoms, concerns, and I know at least at the high school level, which is where I am stationed, the teachers are phenomenal about sending me an email. Hey, can you check with this student? Something's off. They're great about that. We also have in our computer system an alert that comes to me and to administration if a student writes anything in an email on a Google Classroom that is questionable. I'll get a securely alert, which 90% of the time is just because they said, oh gosh, some days I just feel like I want to die. They don't mean that, but it still prompts us to check with that student to make sure they don't mean that, to make sure that it's just a phrase that they've used flippantly and they don't realize that, yes, we do have to follow through with those. So that has been huge for my office, being able to touch base with those kids who may think they're flying under the radar and they've created, this fictional story, which is very dark. So that alerts me and I call them in and we start having conversations about that. And that's where it begins, for a lot of those students.
Well, I'm gonna ask the question of the panel. So, gender identity, these kids are taking on avatars. We've seen the start of the trend for years. Have you seen an increase of problem suicides? The statistics should start to show all this. How has that impacted your areas of expertise? I mean, you've got tons of training, I'm sure, because it's all the same here. The girl walks in and says, she's 8 years old, she goes, well, I think I'm a girl. I think I'm a boy. We have to slowly walk through that, because we're going to we're going to stand on what the Bible says, but we also want to make sure that in love, that we're going to have to get to that stage saying, okay, so maybe we need to refer this family, because they may be saying, yeah, let's get this kid, but we love them, they can do whatever they want. And then you end up statistically showing these kids are full suicide down there. So how's that impacted your areas?
At the school level, our role is not to bring faith
Right.
and religion in. So that's kind of off the table, even if you want to. One of the things that I have consistently attempted to do, and I think this is what we're directed and what we're called to do, is first you love them where they're at. You accept them where they're at. And that then begins those open conversations about the struggles with gender identity. It's not for me to judge how they feel or what they want out of their life or their goals. But my role is to help try to mimic that balance, that I talk about on a daily basis. Is, we have to find that balance. When you feel overwhelmed, when you feel out of control, when you feel judged, when you feel hated, when you feel outcast, what do you do with that? Because whether it's gender identity, whether it's anxiety, whether it's depression, most human beings have felt that way.
Or even getting bullied.
Yes, and bullying is the same thing. Most people that you talk to will have experienced that. So where do we go with that part? Is where my role is in the school system.
Can we go ahead?
We don't discriminate by any means. We take LGBTQ plus patients every day. I don't know the extent of what the therapy programming looks like for those individuals, but I do know, as LaDonna was saying, we help process the confusion and self-identity that they might be facing. So, and I know that we respect, their identity while they're with us. So,
We've seen an increase as well. I think, all of us have. And so, again, we meet them where they're at and work on the issue at hand, and if it's because of if it's depression, although they're, identifying as whatever gender they're identifying with, we're going to address the issue at hand.
And I think, we talked to you, LaDonna, earlier, that right now, I mean, you have the TikToks, you have a lot of the social media and everything, so young kids are very influential. And so they're going to actually take on things that they think they can get attention and have a voice. And even the idea of depression is on TikTok a lot, and so they think automatically, well, I'm depressed, but it's just more or less of attention. But let's go ahead, and there's some questions in the audience. Okay.
I have my youngest daughter, right before we moved to Cape Girardeau, was sexually abused. And as she got into puberty, and she had been through Christian counseling, she'd been in Celebrate Recovery program for children, everything. But like you said, TikTok and all of that stuff is out there. She just started thinking, I think I've got gender dysphoria. I think I've got, that maybe I'm bi, and just really got drawn into that whole dark world. And we did counseling in later when she was said, I want to go to a counselor, and that helped her begin to move past that. I'm so thankful, but all of the trans LGBT, I keep seeing testimony after testimony on YouTube videos and so forth of kids that have said transitioning, they just stopped out, was gonna be the thing that was gonna change their life, and they said it didn't help, it made it worse. And then they would start leaning towards suicide. And it's like, I just feel like that whole root issue of abuse, because so many of them, that's exactly where it started, that whole confusion because of what happened to them and so forth. So I just feel like, I mean, I didn't hear anybody address that, so that's why I was bringing that up.
Do you want me to take? When kiddos are developing and they're growing up, there's so many things that influence. And we can't always control that. And we don't always know specifically what their circumstances are, what they're thinking, what they're feeling. As far as where I'm at, which, I would address the present. That's the most important. As long as, we convey consistently across the board, whether it's teachers, administrators in my setting or myself, that, what you feel is what you feel. Feelings are not always honest. They're not always reality. Feelings a lot of times will lie to us. I don't know if that's what's going on, but I do challenge my kiddos in conversations with me that, there are some things I would like you to think about. Do a lot of self-evaluation. If you find yourself overwhelmed, if you find yourself in a dark place where that's kind of where you've unpacked and lived right now, then we need to seek out some extra support. If that means going to a program that specializes in LGBTQ, okay, we can do that. We'll refer to that. If it's Christian counseling, if that's what they want, we will try to refer that way. I mean, again, I can't stress enough, our reaction as professionals a lot of times has more influence than a parent. Our reaction when they start talking in a school setting, because we have them 8 hours a day. Most of the time when the parents have them, they're in their room. If the typical teenager, they're in their room, they're with their friends, or they're on social media, which is just, as far as I'm concerned, a lot of times a cancer. It breeds hate, it breeds darkness a lot of times. On the flip side, it can be very positive. It can be those connections to those services and answers and help that's needed. It's just to kind of try and help guide towards the positive rather than, I'm worthless. You can tell your kid that, no, you're not, you're loved. That doesn't change the feeling necessarily that they have. So when we all remain consistent and again try to usher towards that balance and let them know that, feelings, you're going to have them. You're going to have confusions. You're going to question things all of your entire life. We all do. But it's okay to talk about those. It's okay to say, hey, I'm confused about this. And a lot of times that's where parents get scared. They don't know how to respond to those things. So that's where all of us kind of step in. To hopefully, we want to be proactive to prevent those crises where the police department's not called or where that's the goal, is to start early on in elementary school and walk them all the way through. Do we always have a win? No, we don't. We
And
don't.
I would just say, I was a homeschool mom, so I was with my kids all the time, and, I did everything I could think of that I knew, but I look now and I say, I would love to get some training, because I'm thinking, wow, just loving your child isn't necessarily enough
Yeah.
without information that will help you know good, positive, things to say. I mean, you can have the best of intentions, but not always get there.
We're human, we're going to fail. Yeah.
One thing I love that you just talked about, what you really said was really key for me was, you're acknowledging that, part of their life, you're experiencing confusion, which normally, if you're confused, I don't want to be confused, there's something wrong with me, I can't think straight, and you kind of, the way you normalize that, say, wait, this is going to happen your whole life, let's just walk through this place together.
I do want to say through Boot Hill Counseling Center, not Boot Hill Mental Health, I did go through that 8-hour course just to kind of keep me refreshed. And it is free and it's phenomenal, and I would recommend anybody doing that. It was online when I did it. I don't know if it still is or not, but you talk about some great information that you can put to work immediately. That does contain that.
I think LaDonna hit some things on the head, right on the nail, with regard to what you were specifically bringing up and the trauma, that people experience. And so, again, yes, totally meeting them where they're at, but also at some point being able to work through trauma, because I've heard it, I don't know how many times, even from Paul, you don't see these things. You can't visibly lay your eyes on what somebody's feeling and experiencing. I can't see what you're going through right now. I can't see it. But guarantee you, we're all dealing with something. And now, what do we do with it? In terms of again, I think there was some things mentioned with regard to being reactive and dysregulation, to use clinical terms for a moment, just different things like that. A response, a reaction versus trauma-focused CBT, for instance. Evidence-based practices to get through some of these things. We've come a long ways, and we have to remain educated to be able to address things. And you know what? Sometimes it takes many, many, many tries. And so there's just a whole lot there, that we all have to deal with and work through, and including, clinicians to stay on top of our games. And there's certain things I might specialize that my colleague doesn't. There might be certain things I recognize that this is out of my scope. It needs to be referred, to somebody else to handle those very issues that we're talking about. And I think that's, again, where LaDonna was hitting some things on the head too, but being able to just, know that we're all there to try to help each other and do our best.
Do we have a last-minute question before we close this session on the live stream? Anyone? Okay. What I like to do is thank all the panelists for coming, and if anyone actually has any other questions after this, I'm sure they'll be willing to answer your questions, and hopefully This is just a start for you to go through your journey, to actually understand the issues that are actually out there with mental health, as far as your family members, your neighbors, your community, yourself, and ways to get help, support, avenues of resources, even classes, to actually learn a little bit more, understand and deal with things. So I'd like to again thank everyone.
Thank you. Thank you all.
Y'all taking the time to be here.
Sure.
This is what